Continuing with the etiological phenotypes, I want to show you another example with relatively bad image quality. So we have here a 4-chamber view, a 2-chamber view, where we use the last or the one before the last to interpret, and here the apical long axis. So this is definitely reduced image quality, but still we could use strain imaging. This is the first case of, in this publication I primarily mentioned, the so-called secondary heart failure with preserved ejection fraction, or a possible etiology for heart failure with preserved ejection fraction. So in this case I also wouldn't be sure that ejection fraction is still normal. It seems to be definitely reduced. From eyeballing, I would say we're in the range of 30-35%, so it's more towards the heart failure with reduced ejection fraction. But overall we see that strain imaging still can help. In this case also contrast agent would have helped to delineate the endocardial borders quite nicely and would have helped to differentiate if ejection fraction is truly as reduced as we would think, as we see it in the B-mode imaging. In this case, in this possible secondary HFpEF, we have this typical cherry on top pattern. So we have this apical sparing where we do see the values are still red, or in the darker red color over here, and especially at the basal segments we almost have no longitudinal function of the myocardium present anymore. So even in reduced image quality, strain imaging is a relatively robust parameter. Here we have an example of a still borderline left ventricular ejection fraction, another case of amyloid heart disease with definitely a better image quality. We do see that the walls of the left ventricle, they are definitely thickened. They are not, as I mentioned previously, not necessarily hypertrophied, and also amyloidosis can be a cause. A patient has heart failure symptoms, of course. So when they have still a normal ejection fraction, it is up to 15% of the HFpEF cases we call heart failure with preserved ejection fraction, which actually have an underlying diagnosis of amyloidosis, which we could treat. So in this case, we have to use a certain clinical likelihood and exclude amyloid heart disease in hypertrophied ventricles, or in left ventricles which have a thickened myocardium, especially when we have also aortic stenosis, a certain age, and other factors as well, which make amyloid heart disease more likely. But this also I will discuss in the video on hypertrophic cardiomyopathy and left ventricular hypertrophy, or thickened walls of the left ventricle. I want to emphasize again, so this thickening of the left ventricular walls in case of amyloid heart disease, it's not per se LVH. Also, other chambers have thickened walls, so the interatrial septum, for example, is thickened, the right ventricle is thickened, and here we have this example of the 4-chamber view in a patient with ATTR amyloid heart disease, amyloidosis, and the left ventricular tracing, where you can even adapt the region of interest to even include the thickened myocardium. Here's the example of the right ventricle. Here we see the free lateral wall. The right ventricular wall is thickened. There's a definite reduction in free wall strain and global strain as well. Here, take a look at the free wall strain. It's -18 only, so the normal value, as I said previously, is -23. Also, the TAPSI is reduced, maybe not as reduced as it is written here, but still it's definitely reduced. We do see here the individual values of the segments, and the free wall strain includes those 3 segments. This is the color M mode again. We still see that the right ventricular free wall has overall better values compared to the segments we included of the left ventricle. What else we can evaluate in amyloid heart disease? We can see that the left atrium is also in this case severely enlarged, and we have this restrictive filling pattern and elevated filling pressures. Not necessarily we always have a restrictive filling pattern, but we have a certain degree of hints that the filling pressures are elevated, and in this case we have a reduction of the E prime. So this is the septal, the medial E prime. You see the pulse wave Doppler over here. This is the color coding of the tissue Doppler imaging, and we see it's definitely below 5 centimeters per second, and the normal range is around 6. So it's definitely reduced. And the E to E prime ratio in this patient was elevated as well. Another measurement we can perform of course, is the left atrial strain, and in this case we see a different curve. Of course, in atrial fibrillation we cannot measure the contraction strain because it's simply not existing, so CT contraction strain is not measured, but we can measure the pulse, so the peak atrial longitudinal strain, and that is only 5%, which makes elevated filling pressures also from a standpoint of left atrial strain very likely. This is another example of this patient. We do see this apical sparing. We have the 4-chamber view in the ATTR amyloidosis with the BOSA display and this nice cherry on top, so this apical sparing. And this patient received a therapy for his disease, so tafamidis you can use as a therapy for ATTR amyloidosis.